All right, we are live. Do you want to get us started, Dr. Zahn?
Yeah, let's do it. Hello, everyone. I'm Dr. Joe Azzam, and this is Dr. Mark Riley. We're over here in Los Angeles at Attune Health, and we want to thank the Lupus LA community for inviting us to talk to you guys about an important topic, and that's lupus and viruses and how they may relate to one another. So looking at our first slide here, what matters to us and what matters to patients is on the very far right in this slide. What we see is basically types of clinical manifestations, whether it's skin disease, whether it's kidney disease, lupus attacking different parts of the blood vessels. These are the things that patients notice and doctors see and that we worry about. But there's a lot of things that happen, before we actually see it manifest in your body. And so we look at kind of risks and triggers. So that's on the far left of this page. And we know that there's a lot of socioeconomic risk factors, sometimes cultural challenges, stress events. We know genetics can play a part in triggering lupus and autoimmune conditions. But we know that genetics are not the entire picture of what induces lupus. And so usually there's other triggering factors and things in the environment. And so we have in there a picture of a virus and a picture of the sun. And you guys are well familiar with your rheumatologist trying to remind you for photoprotection to use sunblock because we know that the UV rays from the sun can damage our DNA and induce inflammation in the body. And same thing with viruses. We've known for a long time that getting ill with a virus can cause trigger inflammation and leads us to low-grade, low-lying inflammation that we have all the time if we have lupus, and it causes it to spike. And then in the second column, kind of some of the things that happens on a molecular basis is kind of the damaging events. So the DNA can break. There's different ways the DNA and RNA can interloop with one another. It could oxidize. The mitochondria is the powerhouse of our bodies, and there's DNA in the mitochondria that could be released as well. And then we also see that our blood cells can become necrotic, what we call apoptotic. It means the cells die, and they release some of these molecules and they're exposed to our immune cells. And then in the third column, our immune cells react to that. And so the mechanism of inflammation is that some of these cells, like the DC stands for dendritic cells, these are a type of immune cells that eat up these waste molecules that are released from our dying cells, and then it recognizes them and causes a reaction. So it releases antibodies, which is used to attach to microbes and is supposed to defend us, but sometimes it attaches to our kidneys, and that's what causes lupus to attack the kidneys. And cytokines, which is what we call is the term for inflammatory signaling that cells release. So all this combined together then leads you to the clinical manifestations we discussed, which is what we notice and what lupus patients might feel. You might feel bad and come see their doctors. So going to the environmental triggers, we know that infectious agents are a huge role for what can cause a lupus flare. And again, as we know, the genetics might provide a blueprint for maybe being predisposed to autoimmunity or lupus. We know that environmental triggers such as infections can be a spark, so to say, that ignites the autoimmune process. And many sorts of infectious agents have been implicated in this. Viruses, bacteria, parasites, they can all have been proposed to be a trigger. But more recently, what everyone's been more excited about is the Epstein-Barr virus, or EBV, which you may have heard of. It causes mono. So, the teenage person who might get mono. Actually, most of us, 95% of us, have been infected, or we have evidence that we've had mono, or at least the EBV virus within us. It's a little bit more, even higher in lupus, 98% or so. But there's a new study that came out in December of 2025 that these scientists were actually able to show how the EBV virus can reprogram our own cells to attack our body. So although we've suspected that EBV was related to lupus in some way, we didn't know exactly how it did it. And now we have some proof showing how it does that. And some statistics for you guys. So basically, infections can cause 16% of patients with lupus can develop a flare. Some studies go as high as 19%. So that could be 1 in 6 to 1 in 5 people when they get some sort of infection, they can develop a lupus flare. And that might be kidney disease, skin disease, joint aches. These can all be flares from these infections. And it's not just the EBV virus we discussed. It could be the flu, which is influenza. It could be shingles, norovirus, which causes a stomach gastroenteritis, diarrhea, and vomiting. And then, of course, COVID-19 as well, which we'll get into later. A little bit more on the Epstein-Barr virus connection. So, this is a picture of a virus which has a surface. It's like a circle and encompasses the genetic material of the virus. When that virus enters our cells, it attacks our cells, it injects its genetic material into our own cells, and then our cells, then it integrates into our DNA, so to speak. And so what they've shown was that the patients with lupus may have reactivation of this virus more frequently than healthy individuals. In healthy individuals, if we've had EBV viral infection, we're able to keep it suppressed for most of our lives. But it turns out to be that lupus patients might have these reactivations more frequently. And as we mentioned, how it can engineer our own cells, what we call the B cells, which these are the cells that create the antibodies. So that's what we want when we give people vaccines, to make antibodies to attack what we're defending against. But now it's essentially taking over our B cells, some of our B cells, and it teaches it to attack ourselves. And so we think, we have B cell targeting therapies you may have heard of, belimumab, rituximab, a new one, obinutuzumab. We think maybe this is why these are effective for our lupus patients. A little bit more detail on how we think that one of the mechanisms of how it causes our own body to mistake our own body for an infection to fight. And so we attack ourselves. It's called molecular mimicry. So to mimic is to copy something. And so there's a viral protein for EBV specifically. It's called EBNA1. And this is a protein that is native to the virus. It turns out that it actually mimics one of our own proteins in our bodies called Rho, or SSA. You may have heard of this one as well. And there's a cross-reactivity. So we see that the B cells start making antibodies to attack EBNA1, but because they're so related to one another, it can also attack the Rho antigen protein in our body, and then which causes autoimmunity. So that's kind of one of the mechanisms that it can do that for. And then something else interesting that we're learning more and more about, you guys may have heard of microbiome, our gut microbiome and all the healthy bacteria and flora that lives within us, and sometimes could have an imbalance and lead to certain conditions. Turns out there's something called the virome as well that we don't know too much about, but we're learning more and more. And there was a study looking at 6,000 people. This is in Japan, and we're learning there's a group of viruses called anelloviruses, and these are actually within all of us, and they're a healthy group of viruses. But it turns out when they study lupus patients, that there may be an imbalance with these anelloviruses. Maybe they go up a little bit more, and that's a finding that these scientists have noted. And there's also another form of virus called HHV6B. This is also within most of us, but acquired in another way. And it's not acquired through just like sneezing and catching someone with a cold, but there's some other mechanisms that they're trying to work out. And they think that lupus patients, when they have one of these viruses within our own virome or microbiome, this is developing into a field called endoimmunity. So the immune system kind of within us. So this is kind of exciting stuff that's being looked into. And so there's more to come from this, hopefully in the near future. And one molecule of note is something called the interferons. The interferons are molecules that our own body uses to attack viruses. Some of you may have heard of interferons or maybe something called interferon signature. And this is something that we see in lupus patients where there's certain molecules of interferons that are elevated in the blood. And this was utilized by pharmaceutical companies, and there's a medicine that blocks interferons actually. But naturally, what this is supposed to do is attack viruses and protect us against viruses. So after viral infection, we release interferons, and it can lead to autoantibodies and downstream inflammation, which is what you see in the picture. There's receptors where the interferon attaches to. And then downstream, and it goes to the DNA, and it causes us to make proteins to react to this. So when we have the endoimmunity or the viruses that, like what they showed in the most recent study in December, we think that there's a triggering of this interferon constitutively. And so there's always some low-level Lyme inflammation in lupus patients.
I'll take it. All right. So Dr. Azzam's talked a lot about Epstein-Barr virus and then the viral genome that is related to our bodies. Well, although we're a few years removed from the height of the COVID pandemic, it's still, as you know, throughout and endemic in LA and other areas too. But that actually provided us with a very interesting view of how viruses can relate to the immune system, just with a new virus that had come about. And one of the things we knew is that during COVID-19 infections, and some of you may have experienced this yourself as well, is that we do know that in similar fashion to with other viral infections, that COVID-19 infections did seem to lead to increased disease activity in patients with lupus and other autoimmune diseases. And in some patients who we think are genetically predisposed to autoimmunity, that it led to the unmasking of lupus features at the time. And I think it goes back to this feature that it doesn't necessarily have to be Epstein-Barr per se. I don't think it's every single virus that can trigger an autoimmune disease, but there does seem to be this group of viruses, COVID-19, Epstein-Barr virus, and influenza, among others, that really seem to be, perhaps for lack of a better term, immunogenic and kind of really induce the body's immune system to misbehave and kind of go after some other parts of the body that it really should be leaving alone. So during when we talk specifically about COVID, there's this protein that has been discovered called ORAF8 that that seems to have some structural similarities to a compound called IL-17A, which we see a lot more commonly in conditions like psoriatic arthritis and spondyloarthritis conditions. But that can also be active in a variety of inflammatory diseases, including lupus. We do know that that seems to lead to, as I mentioned, sort of an even broader inflammatory response than just strictly the IL-17 marker itself. So it goes into the fact that there isn't just one marker that is, well, there are a variety that can be targetable. There really is a strong interplay with the immune system. And that's what makes some of these conditions like lupus just so complex and interesting for us to continue to study. But we also think that, IL-17A in particular does lead to It has a significant impact on the joints, and we know it directly does drive joint inflammation and can actually lead to joint and bone destruction as well, leading to what we call erosions of the joints. We briefly touched on the flu a little bit, but you know, what some of you folks may be also thinking about what sorts of things can you do, and how does this also play into sort of day-to-day life, especially now that you know, we're sort of in the winter time a little bit, and that influenza is also a common thing and very prominent now. We don't think that lupus patients are any more or less likely to get infected with influenza. It just is a highly infectious agent, and it's very likely to cause infection in a large number of people. But we do know in a similar fashion that influenza can also seem to trigger increased disease activity in lupus. And it doesn't have to be lupus features that someone has already had. So if someone has characteristically had skin disease historically, this could be a trigger to develop another component of their disease, such as joint disease or even kidney disease. So it's something for us to be very cognizant of, and to be very vigilant, excuse me, both as doctors and patients, for us to make sure that we're monitoring very closely during these periods of time. And, you know, we think that ways to kind of protect yourself, really, even though I think this year we've had more like a higher virulence of a different type of influenza that hasn't really been all that well covered by the current immunization for the flu vaccine earlier this year. We do think that that is still something that we strongly recommend, and it does reduce risks of disease activity, and also as that pertains to lupus too. So, you know, we've talked about other more common viruses, but other ones that we do know of, norovirus that Dr. Azzam mentioned, some other ones that are a little bit less common, such as dengue, chikungunya, and Zika, which was more of an issue several years ago. We do know that these viruses produce a variety of different proteins that seem to mimic particles in our body, and also do seem to induce a variety of autoantibodies being produced too. And I will point out too, also, just with a variety and changes of weather patterns over the course of the years, that these viruses may also become a little bit more commonplace as time goes on. All right. So talking about vaccination strategies and how best to control this. So, you know, in general, in large part, for most people, it is recommended that you get vaccinated for things like influenza. And we'll talk about some other ones a little bit later. But in general, we think that the best times to vaccinate are when your disease is under good control. Those are going to be the ideal times. The vaccines in general, getting inactivated vaccines, particularly for patients who are on immunosuppressive therapies. So ones like that's prednisone or belimumab or rituximab, that some of those are going to be more important and are going to cause less issues with the immune systems. You know, I would say those are kind of broad strokes, but obviously I think everybody's everybody's care is individualized, and it should be. And so I think that it's very important to be speaking very closely with your rheumatologist about whether a specific vaccine is really correct for you. Not every single one may be for every single patient, but in general, it is a good idea to do that from a protection standpoint. So in general, we talked a little bit about the flu, COVID-19, pneumococcal. This is more for bacterial, which is a little bit off of our what we've been talking about with viruses. But the shingles vaccine is something that, especially if you're on medications that suppress the immune system, anifrolumab, which is the drug that targets the type 1 interferon, is one that we do sometimes see a little bit increased risk of shingles. So that would be a particular instance where it's a good idea for someone to be vaccinated against shingles. we did some research actually for preparing this talk to look whether or not there is a vaccine that's been developed for Epstein-Barr virus, because that would be a really wonderful thing, especially if over 90% of us have the virus present in our body. And as it turns out, there is ongoing research to look for this, but it's been a challenge in comparison to, you saw how rapidly the medical community was able to develop a COVID-19 vaccine, but EBV has been a different beast, so to speak, and part of it has to do with really trying to get the correct viral proteins, but there's some worry that there may be some oncogenic or potential malignant potential with Epstein-Barr virus genes. So those have been some roadblocks into developing that, but there is some ongoing research for that, which is exciting. Right. And then other general things about how to manage this in terms of, because we do sometimes get questions about Epstein-Barr and whether or not taking antiviral therapies would be beneficial. Currently, recommendations are that it doesn't seem to really provide much benefit for specific taking like an antiviral therapy. Unlike with COVID, where we have an antiviral medicine that really works for that. But in general, maintaining good hygiene, in general, safety precautions. In large part, patients don't need to stop their lupus medications because sometimes, especially during an outbreak of a period and to potentially prevent a more severe flare, that would lead to more activity. So in general, we don't recommend that. And then just general immune support, really making sure that sleep is optimized, stress management as well, and then also dietary focuses as well can make a big difference too. And that also kind of gets back to some of the gut microbiome components too that can be very important as well. Okay. So just in general, we did talk about a couple viruses, but of recent interest is just that Epstein-Barr virus in particular. They've found some new mechanisms by which it seems to reprogram the immune system, in particular these B cells that Dr. Azzam mentioned, and that seems to be a direct pathway to getting to the manifestations that we see and can know and identify as lupus. So I think there's a lot of very exciting research with this going on in this area, and we're going to be very curious to see how this continues to pertain to lupus and perhaps even other autoimmune diseases, and maybe allow us to identify different disease targets to perhaps identify people who are at higher risk even before disease may manifest. Okay. All right. Thanks so much for your time, and we're happy to take any questions that you guys have.
Awesome. Thank you so much. We really appreciate it. That was so detailed, and it's just really interesting to see all the ways that different viruses affect, the condition differently. If you wouldn't mind taking down your slides for a moment, just so that we can see you a little bit better, and we'll dive into some of the questions that we received.
Sure.
Perfect.
How's
Nice. One of the questions that we got was, does Plaquenil actually provide any extra protection against catching viruses, or is that not true?
That's a good question. So upon my reading of this, and I think from experience as well, there is some level of protection with continuing your Plaquenil when a lupus patient contracts a viral infection.
Okay.
We know that Plaquenil is not very immune suppressing. It's more of an immune modulating agent. And so we're not too worried about people continuing Plaquenil in those states. But it doesn't necessarily mean that when non-lupus patients contract a viral infection, that they need to start Plaquenil. That I don't think has shown much evidence that it's super beneficial. I think they looked at a lot into that with COVID, and some of the better studies that have been done didn't really pan out to be a positive study. But certainly for lupus patients, yeah, I encourage people to continue their Plaquenil for the time being.
Okay, interesting. Another community member asked, if I do catch a virus, should I stop taking my prednisone until I feel better, or does it help with COVID?
Oh, a good question. I can answer that one. So I wouldn't stop taking prednisone abruptly for an infection, especially if it's something that you've continued for a long period of time. What we know, especially for folks who have been on prednisone for at least several months at a time, is that your body's ability to make cortisol, which is a stress hormone, is significantly blunted, and we know that you actually it sometimes goes your body needs more cortisol when it has an infection because it's a stressor.
Mm,
So actually, in some cases, for certain people, if you've been on a certain dose of steroid for a very long time, sometimes we actually recommend doubling the dose rather than decreasing or stopping it. But for someone who has been on prednisone, say for a couple of weeks, and they contract a virus at that point, that would probably be a specific conversation with your doctor.
sure.
But I do think that that prednisone to a degree will kind of limit some of the immune system's response. You may not necessarily feel quite as sick. So I would say most of the time you probably can continue it.
Okay, interesting. Um, Another question that we received is, am I at a higher risk for long COVID because I already have an overactive immune system? Is that something that we can?
This is a really important question. I don't know. Have you seen any data to support an answer for this?
I haven't. I think that needs to be an area of active research.
Yeah.
I think that's a wonderful question.
Yeah, it's a good
Okay.
research question.
Mhm.
Because we do think that when people get long COVID, there is some immune, right? There's an immune activation, neuroimmune axis. And even that by itself is not well panned out. We don't know that we don't have, approved treatments for it. But so we're trying all sorts of different things for it. But yeah, hopefully we get more clarity in that in the future.
Mhm. Yeah,
Okay.
I guess to kind of jump off of that, I think for anecdotally, I think I have been searching for ways to try to figure out who is going to be at higher risk or not.
Yeah.
I think I will say that I do tend to see a lot of folks who may have long COVID or what's also termed chronic fatigue syndrome in the literature. Who have joint hypermobility, among other things. And we don't know the direct connection of that. For other autoimmune diseases, though, I will say most of the time, the vast majority of people who contract COVID generally don't get long COVID. You
Okay.
can definitely feel under the weather and just feel just not yourself for a few weeks. But the folks who really have symptoms for 3 months or more, or we've both seen people who have had years of symptoms after COVID. I'm not seeing in my own practice people who have lupus or other autoimmune diseases being more likely to have that. But from a
Okay.
large scale standpoint, yeah, we need to learn more. So that's a really good question.
Okay. Understood. We have a couple more. I'll pick two more. This one is sort of commonly asked. How do I explain to my friends, social circle, or employer that getting the common cold, in quotes, is a bigger deal or threat to me than it is to them?
Hmm.
Yeah. Well, certainly if you're willing to share some of your health problems, lupus is considered a rare condition, right? We have the lupus community, so we have our peers and we have our lupus participants, and so we're well versed with it. But I think the way to describe it to them is you have a immune condition where you have chronic levels of inflammation, I suppose. And not only that, but when you're on certain treatments, these treatments that we prescribe are a big deal and they can suppress the immune system sometimes. And so it could lead to maybe longer infections. It could progress in certain ways. And so definitely, if there's an issue in the workplace, I encourage my patients, I'm sure you do the same, to kind of message us, check in with your rheumatologist, and I'm sure they'll, write a letter to support you in some way to allow the recovery time that you need of some sort.
Mhm.
Very nice. Okay. And then I'll take one more. Um, I think you actually covered this a little bit on the vaccination strategy slide, Dr. Riley. But they're asking, is there a specific window of time that I should wait to get a vaccine if I'm in a flare, or is it based on symptoms?
Yeah, it's really based on symptoms there. I think a lot of that for me is very individualized. I think that which I know is a little bit of a frustrating answer, but I think that what I would say is that if you have had good control of your disease for, I would say, at least 2 weeks, that would be a reasonable time to go ahead and get a vaccine. I think also that if there's also a question of timing in terms of if you're on treatments. So I will say most treatments that we give, so like hydroxychloroquine in particular, there is no need to focus on timing or holding that medication to get a vaccine. Really, the therapies that we worry about a little bit in terms of your body's ability to make more vaccine and have more response to it is more so with the B cell depleting agents, so rituximab and obinutuzumab. So in an ideal setting, if your disease is under control, then we like to try to time getting vaccinations for close to the end of your dosing cycle so that it allows your body to produce the antibodies necessary to help fight off whether that's COVID-19 or whether that's influenza. Obviously, there are a lot of time frames where those don't perfectly line up. So it might be flu season, and you might be right in the middle of a dosing cycle for rituximab. In an instance like that, those are cases where it's actually better to err on the side of vaccinating because you're going to get some degree of immunity and some degree of protection from the vaccine. And I would rather have that be present rather than not.
Sure, sure. That makes sense. Okay, well, thank you so much for taking the time to answer our community's questions and being here with us today. We really appreciate your time. And if you're watching today, I'll drop the link to sign up to get notified for future live expert sessions. And I'll also put the link to learn more about Dr. Azzam and Dr. Riley and their practice. So if you're interested in the LA area, you can check them out as well. Thanks so much for joining us today.